Welcome back to the NCD Academy panel discussion series on COVID-19. It is my pleasure to lead this final series installment about building back better to put people first in the NCD response. On behalf of the NCD Alliance, I hope you have found great value in the other aspect of our COVID-19 programming on NCD Academy. The course developed with our partners at the American College of Cardiology on recommended care for people diagnosed with COVID-19 or experiencing a chronic health condition during this time of crisis. However, it is vitally important to remember that COVID-19 is a public health challenge. The vast strides we have made in our clinical understanding of the virus will go to waste without strategies that protect our vulnerable people and allow broad access to medical care. That is the goal with this series, to pass out the implication of COVID-19 at the health system level and the unique challenges facing systems in different regions and at different levels of economic development. Today's panel focuses on an issue that has been acute for decades and has only become more dire during this pandemic, meaning the prevalence of non-communicable diseases. The pandemic is putting the long-standing lack of investment in NCD's prevention and control in the spotlight. And consequently, the Building Back Better agenda for NCDs must be a central part of the global health conversation about resilience, recovery, and rebuilding back from COVID-19. My name is Joseph Muchumbitsi. I'm joined today by an esteemed group of experts from across the Middle East and Africa to discuss the challenges of building back better as it relates to our region of the globe. The panelists we have today with me, I have Dr. Kingsley Akinroy, President of Nigerian Heart Foundation, to provide perspective as a physician, identify opportunities to build back better, and share progress in engaging civil society and people living with NCDs in the national COVID-19 response. We have also Hanin Ode, Jordan NCD Alliance, to focus on advocacy to include NCDs in preparedness plan and maintain a minimum level of NCD services, particularly for people in emergency and humanitarian setting. We have also Dr. Adel El Sayed, the president of Egyptian NCD Alliance, to provide perspective as an internist, views on the importance of ensuring strong healthcare workforce for NCDs and universal health coverage, and the role of civil society. Dr. Mutoni Met, our voices advocate and founder of Cancer Cafe from Kenya, will speak as an expert advocate on NCD services disruption and engaging communities and people living with NCDs in efforts to build back better. Those are the panelists with me today. And without losing time, we're going to start with a discussion between the different panelists. The theme number one is about providing context on how NCDs have been included in the COVID-19 response in the different countries in the Middle East and in Africa. Disruption to essential services have been severe during the COVID-19 pandemic, particularly in our low and middle income countries in Africa and in the Middle East. But whether we understand or appreciate the full extent of the problem is the question you have to answer today. That's why we are going to go through the different questions we have been proposed for discussion. And question number one is about how good government are doing to track the impact of COVID-19 on care for chronic diseases, many non-communicable diseases, either through data collection, either through other monitoring ways and evaluation efforts. To discuss this question, I would like to call upon Dr. El Sayed from Egypt to try answer this question about how governments are doing to track the impact of COVID-19 on NCD care.
Thank you very much indeed. Thank you for having me to this discussion today. I'm pretty sure that with this diverse group, definitely will benefit from each other, and hopefully that the whole healthcare worker will benefit as well. Actually, governments have a lot of challenge regarding the issue of the integration between an infectious pandemic like COVID-19 and non-communicable diseases, which are there for a long time and which we are trying to deal with. Actually, I believe that governments have to make use of all opportunities and try to cover the challenges which will be met. I can give you one example from the Egyptian government actually here. Actually, the Egyptian government is rather lucky regarding that issue because the Egyptian government had just finished a huge project called 100 Million Well-Beings, which was conducted during the last couple of years. This project consisted of mass screening and treatment of hepatitis C virus infection. You know that hepatitis C virus, Egypt was the highest prevalence of hepatitis C virus. So during the last couple of years, we had a huge project actually, maybe the largest in the whole history, because they screened more than 50 million persons in 2 years. And together with screening for hepatitis C virus, they screened for diabetes, hypertension, and obesity. This project attracted a lot of international attention as a unique model for international attention, as a unique model for integrating a group of apparently unrelated health problems together, infectious and non-infectious problems. Now, the lesson, one of the important lessons we learned actually from COVID-19 is that integration of health issues is much greater than we ever thought. The Egyptian government has recently, after finishing that project, now they have started a new health initiative called the Presidential Project of Treating Chronic Diseases, NCDs. So with the huge experience with the Egyptian healthcare professionals gained from the previous project of integrating a viral disease, hepatitis C virus, with NCDs, diabetes, hypertension, and obesity, it will be easier to integrate another viral disease, which is COVID-19 this time, with NCDs into this new initiative. So there are measures included in the new project actually marketing that integration, like online consultations, like widening the periods between dispensing the NCD drugs to people living with NCDs. Maybe make it every 3 months, for example, or even longer. And taking the opportunity of getting in touch with NCD patients to educate them about the special importance of COVID-19 prevention in their case and the preventive measure they need to take to decrease the virus spread, which is much more serious to them with their NCD diseases. This is a sort of example on the behavior of government in this challenge part of our time. Thank you.
Thank you very much. Thank you for your insight and the example from Egypt. May I ask Dr. Kingsley maybe to give also his views on this question as how good governments are doing to tackle the impact of COVID-19 on NCDK. Dr. Kingsley?
Thank you very much, Joseph, and also thank you very much, Adel, for this. It's a great opportunity, and also want to thank the NCD Academy for this opportunity. Well, in Nigeria, you remember that no less than about we passed through Ebola. Ebola was quite a very unique experience, which was very devastating. And Ebola entered Nigeria through Lagos state. And that is also part of our history. But nationally, I will also say that not recently, just before the COVID, the Nigerian government just approved the multi-sectoral plan for non-communicable disease at the presidency. It was just approved on paper without funding yet. And also, the universal health coverage was just under discussion, also currently under discussion. And it's just been, we have 36 states. Funding was just about to start only in 12 states. Those were the opportunities on ground. And I must also add, when you say how good, I will also say that there's, in terms of investment in non-communicable disease, our country, Nigeria, has not been very prepared. But we have the history of Ebola. And if I want to say that Lagos State, out of the 36 states, was where Ebola entered and has a good experience. A couple of months before then, the Lagos State government, in partnership with a foreign government, started the Biosecurity Center. And the Biosecurity Center was being fortified, and there was training being done for healthcare practitioners in Lagos State. And shortly after then, Ebola came in. So you will see that most of the activities that we gained in Nigeria was from Lagos State. The whole of the country, the whole of other 35 states were not prepared. So the gains of Lagos State was very, very good, being that they were prepared. Of course, the federal government had to borrow a lot of knowledge and experience from Lagos State to be able to tackle and spread this to the other parts of the state. So in short, it was really an epidemic, but there was quite a lot of experience. And I was also say that our universal health coverage was still in the infantile state, but that has now improved. We also have the primary care system in our system, which was there, which was also a missed opportunity that was not being integrated into NCDs. So that is how prepared the government was. Thank you.
Thank you very much, Dr. Kingsley, for your intervention. I think we need to go to the following question. It is also about the government actions to tackle the NCDK. And the question is about, at the governmental level, what measures should legislators and policy experts be taking to reduce the disruptions to NCD services and measure their effectiveness? Because we know that according to WHO report, we have seen that more than 66% of the countries had disrupted services for NCDs, and we need to see how in Middle East and in Africa we have had good responses to avoid the disruption of NCD services? To answer this question, to ask, I think it will be also again Dr. El Sayed to try to answer this question about what measures legislators should be taking to reduce the disruption of NCD services.
Thank you again. Governments have a lot to be done actually, especially in the field of legislations, because we need a hell lot of legislations. If we would like to integrate the NCDs into the plan to face the problem of the pandemic of COVID-19, definitely we need legislations in favor of surveillance and prevention and treatment of NCDs. This should be an integral part of the plan to face the problem of the COVID-19 pandemic. And again, well, we in Egypt have actually a lot of huge challenges regarding the legislations which are required, because we have got a lot of smoking, for example, over there. We have a lot of problems regarding that. Obesity is market. I mean, sedentary life is very prevalent. So we have a lot of challenges actually, and one aspect which we need is legislations. We need to include the parliament actually on board just to be able to move through these issues. We have a huge challenge, I have to say, and we are far from being perfect actually regarding that. There are a lot of what must and can be done. We need a huge work in both levels of legislation and implementation. As we are now speaking on legislation level in particular, we have another interesting opportunity here in my country, in Egypt as well. Another opportunity we have. Just 1 week ago, we finished our national elections for the second parliamentarian compartment. The first compartment was finished 1 month ago. So we now have a brand new parliament. I believe this is an excellent opportunity which should never be wasted for health policy makers in this country. We need to initiate a strong awareness campaign for the new parliament members. In addition, we need to form a health advocacy parliamentarian group. And this is a very successful step, by the way, and it would be easier when you have new people into the parliament. And we need to put data. We are preparing now to put data in a simple and clear way in front of those people who are not specialized. Then we have to carefully discussing with them what we need for the Egyptian people health, not only in terms of COVID-19 transmission prevention. This is the focus of interest of everybody, but we need to educate them that this is not the only thing which we would like to do, but prevention of transmission of COVID-19 disease is very important, of course, but also we have to plan for facing the NCD problem, which is not less important. That issue has to be explained clearly to the people of the parliament, and it's very relevant to the first issue of the infectious disease. Legislations aiming at decreasing tobacco smoking rates, improvement of food quality by decreasing sugar content and by getting rid of hydrogenated fat, for example, encouraging physical exercise. These legislations should be prioritized to come on the top of the urgent list, which has to be put during this period. Thank you.
Thank you very much, Dr. Sayed. But I would like to, the question is mainly about also how we can prevent or avoid disruption of services for NCD care. And I would like to ask Mrs. Hanin Ode from Jordan, maybe to give us her point of view in her country, the experience about how Jordan has tried to avoid disruption of NCD care in their country.
Yes, thank you, Dr. Joseph, and thank you for the NCD Alliance for organizing this session. Avoiding a disruption in an emergency context is a challenge for a lot of governments, and it has been a huge challenge for our health service delivery and the Ministry of Health, as well as the Jordan government as a whole. Not only because of the COVID that has been at the very beginning, there were lots of variables, lots of unknowns, but also Jordan has been hosting a large number of refugees as well. And, while we are still in the middle of doing our response plans for this year, and as a government and as civil society and multiple actors, but also COVID came along to add to that kind of burden, and particularly to the health sector. I think in order to avoid the disruption for access for NCD's patients, whether the refugees or not, of course, access to three things mainly. One is medications, access to medications, ensuring access to information and education for NCD's patients, and ensuring that they are able to learn and to know in a timely manner how to protect themselves, and especially in light of the fact that NCD's patients could suffer from complications of COVID if they contracted COVID, and this has obviously created the need to do specific communication with NCD's patients and their caregivers and their families, and even the healthcare providers, on what COVID is like for an NCD patient, and what are the risks, what are the dangers, how NCD's patients can cope, and how can they protect themselves, and how they can access care with the least level of risk of contracting the disease. In addition to that, I think access to counseling and care, and ensuring that they are able to discuss their issues from home in a way that would comfort them and support them, and they would not have a disruption in that. In Jordan, at the beginning, of course, Jordan has forced a very strict lockdown that lasted a few weeks consecutively, whereby nothing was open. Maybe at the later stage, the health facilities and the health centers were open for patients, but at the beginning it was a complete lockdown, and one of the strictest in the world, I believe. So the government of Jordan has, with support of multiple agencies and civil society, was able to conduct some delivery mechanisms for medications. They were able also to, with Jordan, for example, we work a lot with the Ministry of Health at the Royal Health Awareness Society. A lot of the NGOs who have a healthcare aspects and delivery were able to do some telemedicine, create some telemedicine platforms to engage, to keep the access for patients available, as well as we've launched several campaigns, and some of them were particularly targeting NCD's patients with messages, information, and also who to call, what to do in case you needed any support. And most recently, the Ministry of Health has done some data analytics on looking at how many of the patients that are in critical situation or non-critical, etc., are NCD's patients that are COVID cases, confirmed COVID cases. So that helps the government to respond better. So I think also data gathering is very important to ensure the continuation of the whole services and delivery accessibility and inclusiveness for NCD's patients. Thank you.
Thank you very much, Mrs. Odi. So I see you mentioned telemedicine, which is something which is not always available in most of the African countries, as far as I know. So that's something we need to learn about. But in the interest of time, we need to go back to the program because we have spent a bit too much time on this question. Now we come to the theme number 2, which is about the role of civil society, and including not only health professionals, but also people living within NCDs, ensuring that NCDs are addressed as part of the NCD response. Organizations dedicated to health, such as hospitals, government agencies, and multilateral organizations, are major players in building back better. But we ultimately depend on civil society to ensure that the primary health care is operational. Pre-pandemic, the NCD Alliance put forward the recommendations to better harness a key constituent of civil society, the health workforce, through our report, the report named Protecting Populations, Preserving Futures. And we need to see how civil society, different components, should be leveraged to safeguard care for chronic disease and NCD care in the context of COVID-19 recovery. Which brings us to the question number 3, which is about the strategies that in your different countries you have observed that have effectively engaged community members, including health professionals, NCD advocacy, policymakers, and care delivery in the context of COVID-19, and what further strategies should be adopted. To answer this question, I would like to call upon again Mrs. Hani Ode to try to answer about this question on how community members can be effectively engaged to make sure that to ensure NCD care continuity.
Yes, thank you, Dr. Joseph. I think from a civil society perspective, we were able in Jordan to engage community members in the response to COVID, and particularly to support the service provision for NCD's patients across the country and at community level. I think one of the things is investing in community health volunteers and community health workers. I think that this is a golden opportunity for countries to look at structuring or including in their structure community health as part of and a very important means for delivering on universal health coverage and also on delivering on primary health care that is of quality and that can help whether for communicable or non-communicable diseases alike. But I think that this was a good time to look at this, the value that volunteers, health volunteers can bring on the ground. And of course, some of them were nurses, were midwives, and are NCD's patients, naturally. And they are able to leverage their presence in the local community, especially in times of where governorates were not able to access each other. There was lack of mobility. So the more grassroots you are in the intervention, the better, and maybe in that case, the more impactful, and you are able to do more in less time, utilizing community outreach. This is one way. And also community health workers were able to help with delivery of medications. They were able to group and do some WhatsApp groups that are also very targeted to NCD's patients in order to make sure that they become the communication vehicle between them and other and the doctors or any sort of care and advice they need. Also, I would like to mention here that hotlines were created free of charge. You mentioned, Dr. Joseph, that in some African countries, maybe Wi-Fi or internet services are not available for telemedicine, and for maybe smartphones are not that present. In Jordan, it's not the case. However, we were still able to have hotline for mental health, which is something that was very essential as the fifth NCD on its own, and I think it was exacerbated during the COVID, whether for NCDs themselves suffering from stress, anxiety, and especially the elderly, etc. So some organizations and civil society had a hotline for mental health services. There was a hotline for tobacco quitting and supporting in tobacco treatment. And there was also a hotline for general COVID inquiries and in order to provide people with equal opportunity to access any kind of care. So I think there's always the opportunity to leverage on community members, on healthcare professionals, but more on the community health as a concept and primary health as a concept in these situations, because I think that really adds a lot of value for, like I said, communicable and COVID and NCDs alike.
Thank you very much. You are bringing in very interesting suggestions and initiatives you mentioned from your country. I'd like to ask to Dr. Kingsley if he can step in about the different strategies that have been observed effectively to engage community members, to engage health professionals in the context of Nigeria. Dr. Kingsley?
Thank you very much. I'd like to make a contribution on the effect or the impact of the public-private partnerships. At the outbreak of COVID, and when the level of awareness grew up, and the government also made announcements and to call for help. It was the first time in my country, Nigeria, to see organizations coming out themselves, especially multinational organizations in the oil industry, in the banking sector, and also in the insurance sector. They all came out to raise a fund And not only the raise of funds, they also went out to be able to build what we call the our isolation centers. So this was a cry that has never been before. And we could see that substantial amount of funds was raised within the country that was even scaled the budget of the Federal Ministry of Health in the country. So that means it is possible. So this COVID has also given us an impetus. It has given us initiatives that this could be done, that the health sector too, even though what we say all the time is that there's no fund available in budgetary allocation to help, but it can come when you have effective partnership, especially coming from the private sector, coming from the other regions, and the only thing you need to do is to put in place process to make sure that implementation is carried out effectively and with the advice of the professionals. So this is one area where you see even with the community and within the populations, people also came out to be able to give hand and to be able to see that things are done. And not only that, some people even came out even to donate equipment to be used in hospitals. And so this our added values as form of experience during the COVID era, the pandemic. Thank you.
Thank you very much, Dr. Kingsley. Yes, we heard you. Thank you very much for your contribution. I have to say that in terms of strategies, I would like to mention from my country, from Rwanda, the multi-sectoral approach in terms of collaboration between the different components of the health professionals, civil society, where the Rwanda NCD Alliance has partnered with the Ministry of Health for a countrywide campaign, not only for awareness, but also for bringing some essential medicines, particularly insulin, during the lockdown period to the different hospitals and NCD clinics, which has allowed to organize and try to avoid as much as possible the stock out of essential medicines. So, and that has also, that collaboration has continued up to now to make sure that civil society and Ministry of Health and health facilities can exchange information to make sure that essential medicine remain available. Now, we should go to the next question, which is about for alliances where the civil society solidarity fund on NCDs and COVID-19 has been implemented, and Rwanda is part of those countries. How we have been supporting and advocating for the meaningful involvement of people living with NCDs in the COVID-19 response. I will, Dr. Kingsley, are you ready to start talking about responding to answering this question about support and advocacy for involvement of people living in NCDs?
Oh, thank you, Joseph, about this. Well, in Nigeria, we were involved with the Solidarity, Civil Society Solidarity Fund. And this came up in July 2020. That was just about 2 months when we had been in the epidemics. And we are really very, very grateful to NCD Alliance for providing this grant. Before this time, there was no real group of people living with NCDs. They were individuals in silos. But with this grant that we had, what we did in Nigeria was to make a call on the NCD Alliance, especially the core members of the NCD Alliance were grouped together, and we identified that the 4 core members, that is the Cancer Society, the Heart Foundation, the Diabetes Association, the Sickle Cell Foundation, and the Thoracic Society, should go back and nominate 25 members of the people living with NCDs all over the country. And through this, within a month, we were able to get about 100 people living with NCDs. And the idea was to also to be able to bring these people together as an effective group and organize them into a forum. What we were also trying to do is also to build up their advocacy capacity. And after doing that, we are also able to gather data for the first time. We're able to gather data from them, gather data on their information and what do they know about NCDs, and also about their rights and what has been their experience. They are also living experience with NCDs. So having done that, we moved ahead also to be able to get in 4 states of the country, to be able to get 40 out of these 100 people, which we got all over the country. So we got 4 states, and we got 10 members living with NCDs, various NCDs, and also we were able to be able to talk to them, and also we were able to give them a virtual training session. And after our aim is to also make them as champions, 10 per state, and also be able to group them together. Following this, we moved ahead to be able to get 8 lead champions out of all this. Also reinforcing their capacity and making them also to work with the Ministry of Health of each of the states, and the people are members of the NCD Alliance in the respective states. So this is how far we've gone up till October, and our aim is also to be able to let them to be able to have their voices, to be able to lend and build their capacity up, so that they will have a forum of people living with NCDs in Nigeria and in each of the 4 states. Even though we have 36 states in the country, but we feel that by the time we have 4 states, and with these members that are there, they will be able to form a backup to be able to form a national association of people living with NCDs. And our aim is that the NCD Alliance, which is the parent organization, will be able to be at the background and also let the people living with NCDs have their own voices. They will be able to engage their legislators in the state. They will be able to engage even the media, and their voices also will be backed up with whatever is being done. And they will also be able to contribute to the progress and backing up the tackling of non-communicable diseases in the country. And we are moving towards the end of the grant, and we feel also they are also going to have their own social media, which they are setting up, and a lot of them also, because of their background, are really ready also to take up this challenge. So this is how far we've gone with the people living with NCDs, getting them to be meaningfully involved. Thank you.
Thank you very much. That's very interesting. In Rwanda, in my country, we have also benefited from that grant. And I would say that essentially our activities went around raising awareness of people living with NCDs through our member organizations, because we have quite organized members like the Rwanda Diabetes Association. We have patients living with cancer. We have cardiac patients who are organized in groups. but we try to give them the opportunity to interact with media and be able to speak out and raise their voices about the situation of NCDs, the different challenges they are meeting in accessing medicine, in accessing specialized services, and that has given very powerful media campaign with through different TVs, written journals, and so on, so that what we are trying to do for the moment is to organize them in groups in the different provinces. We have a very well-organized group in one province, and we are working with the different other groups to empower them in terms of being able to raise their voice. Have not yet, I would say, done more in terms of using their voices for advocacy, but in the different NCD event we have organized, like the World Heart Day. Now we're organizing the World Diabetes Day. Different events are organized. We have always been working hand in hand with the Ministry of Health and the Rwanda NCD Alliance members, so that there are very good discussion to allow people living with NCDs to raise their voice and raise their problems and talk about their experiences. We need to go ahead with the next theme, number 3, which is about preparing for the future, building back better. So not only we are not sure the COVID-19 pandemic is not yet finished, and not only that, there will be also other global pandemics. So we need to make sure that we build back better in the future, and we need resources and systems in place for maintaining a minimum level of NCD services when the next crisis will hit. We need to learn good lessons from the COVID-19 experience. We have the next question we need to answer to is, what do we consider as an acceptable minimum level of care for NCDs? Acceptable, as you understand the word, is quite something you can discuss. But I would like to call upon Dr. El Sayed to be the first one to answer this question. What do you consider as the minimum acceptable level of care for NCDs, and which minimum acceptable level should we aim at? Dr. Sayed?
Thank you very much. I like that question, actually. This is an important, but not a very simple sort of question. It needs a group work, actually, to define what is the acceptable minimum care service. I believe we have to clearly define the minimal level of care for NCDs, and I think it has to be defined on regional levels first. Then every community can adapt it to suit its own circumstances. If I give my personal point of view, I would say that number one is surveillance, discovery. Nobody should be living with diabetes or hypertension, for example. It is totally unacceptable that somebody is having diabetes and hypertension without knowing he or she has the disease. Unfortunately, in my country, for example, in my area in general, half of the people living with diabetes do not even know they are diabetics. And the percentage may be more for hypertension. The second minimal requirement is availability and affordability of the simplest medical care facilities and drugs which are able to control the condition. This is a basic requirement. This is definitely from the minimal care. The third point is prevention. And although prevention is the most important, definitely prevention is much more important than the other two factors. But although prevention is the most important, I put it third because the other two measures are more urgent. This would because there are patients who are suffering and who are exposed to develop complications, so it is an urgent issue. Definitely there are other requirements, of course, but I think these are the most important minimal requirements. Thank you.
Thank you very much. I would like now to hear from Dr. Kingsley. In your context in Africa or in Nigeria, what should be considered as the minimum level of NCD care?
Thank you, Joseph. I will agree with Dr. Adel that he has really hit up. I think the first one is the level of awareness on NCDs in Africa. And in my country too, the level of awareness on non-communicable disease is very, very low. And that means that because the bulk of the care rests with the individual and also with the population. So talking about care, we should look at about prevention, we should look about the information and the awareness that is available, and that needs to be stepped up. We need to do quite a lot about information and to be able to spread the level of awareness. If you take, for example, what happens with HIV. HIV is a good example in terms of the information that was available. We are still, and we had HIV in Africa, the information that is still available with non-communicable is still very low. So we need to do that. We need to, not only with the with health professionals, we need to be in the community. We need also to support more civil society organizations at the grassroots. Multi-society organizations also to be, we have some of them that are even still existing. So we need to support them. We need also to be able to let the faith-based organizations also be able to be part of it in terms of this awareness and passing up. Of course, those of us in the NCD Alliance, we are doing what we can do, but we need to do more. The other next level is the accessibility. And that was not, you could know what happened during the outbreak of COVID, when everywhere was locked up. To be able to even access primary healthcare centers was a challenge. So that means too, we need to have more primary healthcare centers that are accessible, that are not far from the locations that are not far, and that also can offer those services. So we also need to talk about accessibility. And lastly, funding, purchasing power. We also need to look about minimum what is support that is needed. Let me also mention what happened in my experience of malaria. Malaria, maybe in the 70s, 80s was very, very, very expensive. But now it's very, very cheap to even to treat malaria within the household. So I believe in Africa, we should get to a certain level where drugs for non-communicable diseases are easily affordable in whatever way we want to do, whether through the normal health insurance, through the normal universal health coverage, or through community insurance or whatever. So I feel that we need to be very innovative, or we need also to support to be able to say that people have accessibility and they're able to afford it, and that also will be able to promote the minimum level of care that is required. Thank you.
Thank you very much, Dr. Kingsley. You mentioned universal health coverage. I think we need to emphasize more about that, because if one of the biggest barriers in our low and middle income countries is about access to care and the hardship, the financial hardship and the high cost of care. So, of course, without universal health coverage, people living with NCD will never have access to care, even if the care is available. But most importantly, I'd like to emphasize the fact that the challenges of our low and middle income countries is also about availability of specialized care. Yes, we need to put an accent on the primary health care. You should be able to test for blood sugar, for hypertension, for have access to early diagnosis of the different cancers. But when it comes to specialized care, to availability of the technology for diagnosis of cancers, for example, and also the COVID-19 has shown that most of our countries do not have specialized care like intensive care to help the COVID-19 patients, particularly when they are sick of and they have NCDs and COVID-19. So I think we need also to call for, I would say, global efforts to help our low and middle income countries to get the necessary equipment and to have access to the specialized care. When you think that in most of the countries in Africa, there's no radiotherapy, how can you diagnose cancers and not be able to offer radiotherapy to your patients? So I think it is also, we shouldn't forget about the specialized care. Now, having said that, I think that we are now close to going to the question number 6, which is about how NCD care should be part of emergency preparedness and available to people living with NCDs during the future pandemic. That's a very difficult question. And to start to answer to that, I would like to ask Ms. Hanin Ode to give us her views about this question.
Well, like you said, Dr. Joseph, I think that's not a very easy question to ensure, but and it comes as the last question. So I think I will take away from, I will take from the all the lessons and the great examples that were mentioned by the panelists. One of the things is definitely advocacy, ensuring that we are advocating strongly as civil society and the government and the community to include NCDs care in any response plans and in any preparedness plans. I think we've had an example of including NCDs in humanitarian, for example, humanitarian preparedness plans and also response plans in Jordan, responding to the refugee crisis that we've had recently because of the war in Syria. But I think we managed with advocacy to include NCDs as one of the core issues under the health sector. And there was a specific working group on this issue. I think the issue of including and advocating, also this would lead into ensuring that there are budgetary commitments and fundraising and financing means available. And also partnership and coordination and collaboration with civil society is essential because, when we did closure at the beginning, civil society organizations were not allowed to operate in the first days or maybe a week. And that has had its cost on the availability of access to care for NCD's patients that used to benefit from these facilities. So I think partnership is very important. Involving people living with NCDs also in those planning, in those taking stock and learning from the lessons of the challenges, of the needs that were not met, and how we can work together to bridge those gaps to a certain extent is very important. And I would conclude with by saying, it's very important that we sustain the wins that we had. COVID, yes, has been very harsh on NCDs in particular, but it also had its opportunities that rose because of COVID. Investment in innovation, investment in certain technology means, ensuring that activating the role of community health workers on the ground, and also I would say even at policy level, advocating for the closure of, and I'm sure Dr. Adil from Egypt would relate very much to this, the closure of shisha places because of COVID, for example, and the ban of shisha. And this is, one of the most consumed tobacco products in our region. And banning it because it is a hazard on COVID is not so bad after all for NCD's care and prevention and secondary prevention. So I think sustaining those wins and advocating now, as we are currently facing the many, increase in numbers, let's use this opportunity to sustain all the different wins that we had. In lockdown, people were allowed and were encouraged to walk. In the World Diabetes Day, just 2 days ago, we launched a walking challenge because people could not walk together. So it was through walking individually, but in a group on the app. But it is essentially really encouraging healthy lifestyle and minimizing risk factors and using the COVID to learn how we managed to respond to COVID so far and what were the successes and building on them. So I think I've reached my 4-minute mark, so I'd leave it back to you, Dr. Joseph. Thank you.
Thank you very much for your contribution. I would like to ask Dr. Kingsley to step in about what should we do to make sure that NCDK is part of the emergency preparedness plans in our different countries, particularly in Africa.
Thank you, Mrs. Annie. You've covered most of the points. My few points to add is that I want also to have a triad of NCD, emergency preparedness, and telemedicine. If we look at those triad and we look at what each of those triad needs to contribute, I think with emergency preparedness and NCD, we will have achieved a lot. And the last one I want to add is that training should also be part, like what Mrs. Annie mentioned about the people who are our other healthcare providers, especially at the primary healthcare level, where the bulk of the patients are. People in the remote areas, telemedicine will be very, very useful. And I feel that's also, I use that triad for all the advantages that it needs to be. So if we, right from the word go after this, make sure that people at the lowest level of care, the primary care level, are all trained in basic emergency preparation. And so if there's any outbreak, they will be able to offer on a wider scope to be able to tackle emergencies. And with the use of telemedicine, maybe from the general hospital, the specialist hospital, the teaching hospital. They'll also be able to make a linkage. And of course, at the end of the day, the level of care for emergency care will have gone up. So I will add to what Mrs. Annin has done. So that is my contribution. Thank you.
Thank you very much, Kingsley. In fact, both of you emphasized about the training. And in fact, when you look at the NCD Alliance recommendations in the protecting population and preserving the future, in that report, they insist very much about enhancing multi-sectoral collaboration to strengthen the health workforce. Because one of the challenges with the COVID-19 is that we saw that primary health care in many of our countries is not strong enough, is not equipped enough. The staff is not enough. The staff is not trained enough about facing such emergencies in terms of that epidemic. So yes, I think that one of the recommendations of this discussion is about enforcing the healthcare workforce. And in my country, we have a very important concept of decentralization and task shifting, because one of the challenges is that we don't have enough specialized and trained workforce. We don't have specialists to tackle and treat cancer patients, but we can, with task shifting, and that's what we do in my country with NCD clinics in the different district hospitals, which are run by nurses, whom we have trained to tackle and manage the most frequent NCDs. With that, we can bring care closer to people so that they don't have to travel through the country to reach the specialist in the referral hospitals. So decentralization, and now we're at the level of trying to bring that those NCD clinic and care at the health center level, which is a challenge because there are many and the staff is not enough, the equipment is not following, but at least we have that, there is that political will to bring care close to people living with NCDs, which become critical when we have to face lockdown, for example, like it was the case at the beginning of the COVID-19. I don't know if the panelists, if any one of you wants to add something on one of the critical questions we have been discussing about. You have a chance now to step in if you have something important you may have forgot. Dr. Syed, do you have something to add about one of the questions?
Thank you very much. No, I have something actually regarding the last question. Specialized care is very important, but we have to have the whole community prepared to integrate NCDs in plans for meeting the challenge of COVID-19. I mean, awareness is very important because for the public even might say, oh, how come that those people are just leaving us with the virus and which is killing people and going to treat people with hypertension and diabetes? They must, it must be clear to them that those with hypertension and diabetes are those who will develop bad outcome when infected with the virus. And if their diabetes and hypertension is not controlled, the outcome will be even worse. I mean, that has to be very clear to everybody in the whole community. This is very important. And the second issue is advocacy, and Haneen discussed it adequately, actually. If awareness and advocacy are there, then we can have the political will. And when we have the political will, the allocation of money will be secured. This, I think, the logic arrangement of issues in the last question. Thank you very much.
Thank you very much, Dr. Syed. Thank you. If I try to summarize what we have been talking about, I think that to the first question, when it comes to ask if governments are doing a good job in terms of tracking the impact of COVID-19, I think we need to recognize that not all countries have been able to have the necessary data, but the COVID-19 pandemic has left good experiences in terms of sharing data, registering the new cases, and I hope we can learn from these to continue tackle and bring together, collect data about the burden of NCDs in our different countries, because that's one of the problems, is that we don't have enough reliable data to really allow policymakers and planning efforts to make sure that they can bring the adequate policies according to the burden of the diseases. In terms of legislations, I think that Dr. Syed has talked very well about the need for advocacy, particularly to approach the legislators, so that not only we have the different risk factors laws to try to contain the risk factors like tobacco or unhealthy food, but also to make sure that legislators put in place laws to protect the population. When it comes to how to engage community members, including health professionals, in the context of the COVID-19, when it comes to NCD advocacy, and in the context of COVID-19, I think that we have all agreed that there are still efforts to be done in terms of advocating for NCD care delivery and to try to do as much as possible to avoid disruption the NCD services and delivery. But strategies needs to be still improved in our different countries. The role of people living with NCDs is very important, and we have emphasized these in our discussion, particularly when it comes to empower the different groups of patients and give them the opportunity to raise their voice and express their, explain the different barriers they have to face to get access to NCD care, particularly in the COVID-19 context. Because if you put policies in place, but they don't, implementation is not reaching the people living with NCDs, the best way to know about it is to hear at the people living with NCDs and hear their voice and give them a chance to express their needs. When it comes to the acceptable minimum level of care for NCDs, I think there's no really answer to this question. Yes, we have emphasized about the need for access to early diagnosis for NCDs, particularly for, we have emphasized about the need for all people with diabetes or hypertension to get access to diagnosis. But we know that it is not only in Africa and in the Middle East, all over the world, half of the people with diabetes do not know they have diabetes, do not know they have hypertension. But in our countries particularly, it is about awareness, not only for the people, the population, but also for the health workers from the community to the different governmental and private healthcare level and structures. So awareness is key to make sure that there is access to care, but also we talked about the need for also specialized care and access to specialized care in the low and middle income countries' health system, and that needs support from the global community and international partners. In terms of including NCD care in emergency preparedness, that's the whole of the discussion about how the next pandemic, and even this one we are still in, will give us lessons in terms of having all the healthcare levels workers aware about the emergencies, having preparedness plan written, and make sure it is our role as advocates to make sure that NCDK is part of the preparedness plan. But in fact, the key point is about strengthening the primary healthcare level and equipment and systems so that they can face not only the different pandemics, but also NCDs and offer the care needed for early diagnosis and care to all people living with NCDs. I would like to thank everyone, every panelist for having given us your insights from the different countries, the Middle East, the different African countries. We have to apologize because we didn't get our panelist from Kenya, but I think he was somehow well represented. And I would like to thank everyone for his contribution and thank the NCD Academy of the Global NCD Alliance for giving us this opportunity to discuss about NCD care and how we can put the people at the first place so that we improve NCD care in our countries. Thank you very much, and looking forward to discussing with you again.